we actually looked at predictors. We looked at
Okay.
factors that contribute to nurses' professional turnover, a bunch of them, infection control policies or access to, PPEs and whatnot. And interestingly, among all the factors that we looked at, we actually found that staffing and workload had the largest impact
Okay.
on people's professional turnover intent.
Welcome to Safe Space Made Simple, a practical podcast that guides clinical leaders and healthcare managers to create trust and support with their teams. I'm your host, Trace Hobson. Join me for weekly interviews, practical tools, and inspiring transformational stories of bringing people together in healthcare. Now, let's dive in. Hi, everyone. Welcome to another episode of Safe Space Made Simple. I'm incredibly excited to have Naz Havai on the show today. Naz is an assistant at the UBC School of Nursing and an avid researcher in the area of nursing, and has also done extensive research in long-term care with the Synergy tool. In today's episode, we go in depth in looking at what Naz is experiencing in the field of nursing as it relates to staffing shortages and psychological health and safety. I enjoyed today's conversation very much, and I know you will too. So without further ado, let's get right into the show. Naz, want to welcome you here to Safe Space Made Simple. Really, really excited to talk to you today. And first of all, it would be great to just understand, what you do, what the work is that you do, and how you got into it.
Yeah, well, thank you so much for having me. I am an assistant professor at UBC School of Nursing, and the other hat that I wear is a health services researcher. Really, how I got interested in health system and health services research, I would say that I actually owe it to my mentor, my PhD mentor, Dr. Maura McPhee, who introduced me to the literature in this area. And, the more I read, the more I felt like there was a need for research on, workplace factors and other factors that impact quality and safety of patient care delivery. And so I started, after doing my bachelor's in nursing at UBC, I started thinking about, graduate studies. I enrolled myself in the master's program. And then that was the place where I sort of fell in love with research. And so decided to, I definitely want to do a PhD. And so from there on, I decided to fast track. So I didn't quite finish my master's degree. I fast tracked the PhD program and I took it from there.
And here you are. So how do you fall in love with research? Tell me what you love about your work generally, but even that comment you just made, I'd love to hear more about what do you love about your work?
I think about research, it's the curiosity that goes with, coming up with an important research question, coming up with a hypothesis, delving into the previous literature to see what has been done on that particular topic. And just, I guess, having a curious mind, because I think personally speaking, I am a curious person in every respect. And so I think because of that, my interest in research, that's where it comes from. It's you need to have a curious mind. You need to have an interest in critical thinking and thinking outside of the box and constantly questioning and sort of having this need for understanding and gaining information and making informed, data-driven, evidence-based decisions. Does that answer your question?
Yeah, that's great. In fact, it kind of answers a little bit deeper because I think about the work you're doing right now, and now I'm getting what's been driving it. And some of the work that I noticed that you're doing when I was doing some research for this interview is incredible. So if you could tell us a little bit, what is Hope Lab and what is the long-term care synergy project that you're working on?
Yeah, so when I actually started my position at UBC School of Nursing as an assistant prof, after doing what I'm supposed to be doing as a faculty person, after a couple of years, I actually established a research lab called the UBC HOPE Lab. Let me see if I can get the acronym right. um, Healthy outcomes through improving patient and provider experiences. That's what the
Mm,
acronym stands for. So really in the Hope Lab, just in line with what I said earlier in terms of my interests, being, studying and addressing those factors that enable care providers, nursing providers in particular, to deliver quality and safe patient care, I established this lab with that exact purpose and vision and mission. And so most of my research prior to the pandemic was within the acute care sector, hospital settings. But when the pandemic happened, with everything that went wrong in the long-term care sector, there was a need for us and our research team to pivot from acute care to this sector. And so I got very lucky, and I received multiple research grants, and was able to actually, start studying the sector, understanding the pandemic management strategies that were being implemented. What were the barriers, facilitators? How were they impacting providers and residents and their family members? Did these pandemic policies, did they have any unintended consequences for this population of residents and family members, and
mm-hmm,
also staff members? So as we were doing some of these research studies, I was faced with, as we always do in healthcare, this issue of workload management and staffing, and whether or not the way we staff um, in this sector is appropriate, it's evidence-based, data-driven. And the answer that we came up with, my team and myself, was that we're actually using very arbitrary standards.
mm,
Nobody knows where the HPRD, hours per resident, the recommended HPRD, is coming from. I specifically looked into the literature, and I wasn't able to locate anything beside a study from the United States that's probably about a decade or 2 decades old.
mm,
So because of some of the work that I had done in acute care, and through my mentor, I was introduced to this patient needs assessment tool called the Synergy tool, which is a really holistic, I guess, approach to understanding, not just understanding, but also quantifying patient needs. So we actually, because of that gap in the way that we staff in long-term care, we actually decided to, sort of bring in and adapt our synergy tool from acute care to the long-term care sector, to understand really the needs of the resident population in this sector, and also to quantify it, and then to use that information
mm-hmm.
from the synergy tool to inform our staffing decisions.
Now, before we go on to what you found, let's just double click a little bit on what the differences are operationally between sort of the model that existed before you started to implement the synergy tool and the synergy tool, and what the differences are. So, what I heard you say is that you found that there was really arbitrary information driving decisions about how to do patient care. And so I'm curious, what did you discover that were sort of, aside from evidence-based reasons, what was driving those decisions operationally, do you think?
So the decision for the recommended HPRD, you mean?
Correct.
Uh, I mean, I'm going to take a wide guess here. Perhaps availability of resources,
Right.
right? Because that always has an impact.
I think I'm sensing a little sarcasm there, Naz.
I'm trying to be very respectful. So
No, it's true, but it's like that is the $1 million challenge for everybody, and the one that comes up over and over again. So availability of resources is driving that decision. So that makes me feel like maybe it was more of a reactive process rather than, like you're talking about, an evidence-based
absolutely,
process, right? Okay.
absolutely.
And
And
how is the
if I
synergy tool, like when you look at that holistic approach, if I was using the synergy tool on the ground or on the floor, what would be different about that approach compared to the old approach?
I think standard approach that we're using right now is not very systematic, and is not systematic, and it's not quantifiable, right? Because nurses go in, do their assessment, complete their documentation, and go through the entire care delivery process without having an understanding, at least in objective terms and in quantifiable terms, of their patient needs. So what the Synergy tool actually does is it looks at 8 patient characteristics. 5 of them are acuity characteristics. 3 of them are they get into the patient's level of dependency, their ability to participate in activities of daily living, their ability to make decisions on their own, their resources availability, and so on and so forth. So what you do with these 8 characteristics is that you go in, and after doing your patient assessment, you actually, based on a series of indicators that we actually identify together with subject matter experts, meaning our nurses and other care providers, they determine whether or not that particular patient or resident is high needs, moderate needs, or low needs in relation to that specific patient characteristic. So they have a number to work with. And so they can essentially use the number to maybe talk to their nursing leader or manager to say, hey, this is really, my workload is really increasing, it's rising, I need some help, or can you think of a way to reject the patient assignment, or get creative and you essentially use the information the patient needs scores from the Synergy to inform their decisions. And the staffing decisions could be in relation to patient assignment. It could be related to maybe bringing in the float person, maybe calling in a workload staff to come in and help the unit, because just the unit workload on that particular shift is really high. So it gives you the tool essentially gives you a more systematic way to think about workload, to understand the holistic needs of your patients, think beyond their physical needs, and think beyond, activities of daily living, vital signs, all that. Think holistically about the person and to measure those needs. So I think it just, I guess, gets at patient care delivery from various respects.
Right. So what did you find in your research? Maybe describe the research projects that you've done with this particular tool, and then what were the discoveries?
Let me actually pull up the paper, because it's been a while. So what we did was we actually got a research grant, first of all, from CIHR to do this work. So it's really important work when your research gets funded. That's a very good sign. It's addressing an important topic. So we actually, the purpose of our research, I would say, was probably multiple fold. The first goal was to adapt the Synergy tool for the context of long-term care, because prior to that point, the tool, it was never used in this context. It was always used in acute care settings, ER, medical surgical areas, maternity, oncology settings. Actually, we had a project back in 2018 where we implemented the tool to understand oncology patients' needs here in BC. So we had to first adapt the tool for this context, the sector, and then to implement it to understand the resident needs, and then to evaluate the impact.
Right.
Does it have, just the use of the tool or the implementation of the tool, does it have any impact on our care delivery, on staff's ability to more effectively meet the needs of their residents and their patients?
So describe which long-term care research studies did you do, and what were the discoveries that you made with using the synergy tool compared to the older models?
Yeah. So, I have to say that first of all, we had to deviate a little bit from our research, the research proposal that we had submitted and was funded by CIHR because of resource constraints. And, we were still during the pandemic and, the stressful context of staffing inadequacies, work overload, all that. We had to adjust something. So originally, we wanted to implement the tool in three long-term care organizations, meaning all of the units within the three care homes would essentially participate. But
Mhm.
because of the pandemic and some of these shortcomings that I mentioned, one of our partner care homes actually withdrew from this study, so
Right.
they did not have the means or the resources. But the two other that stayed with the research, they wanted us to go with the implementation in only two of their units. They purposefully selected two units that were different enough from one another, so that we could actually see if our tool would capture
Mm.
those differences in acuity needs and dependency needs.
Right.
So in total, we had four long-term care units that participated, two from one care home and another two from a different care home. And so in terms of our findings, I would say we did see a positive impact. We implemented the tool for 6 months. So the care team within those units or the care homes, they implemented the synergy tool. They scored the residents that participated in the study in those units for a total of 6 months on a weekly basis.
Mhm.
So we had data for 24 weeks. And what we found was that the use of the tool resulted in some decrease in resident falls, which is a really important
Right.
finding. Although I
Mhm.
have to be very careful with saying that we are 100% confident that the decline in resident falls is because of the tool, because of so many other
Yeah,
factors
of
that
course.
are going on. There are always these limitations in research,
For
especially when
sure.
you're not using the RCT or an experiment approach. But we did see some decline in those units that participated in the project. And then qualitatively, um, we found that the use of the tool actually improved care delivery. It resulted in better communication among the care team and also between the care team and the residents and their family members. And overall, it really helped improve family and staff
Mhm.
relationships. Um, I remember one of our study participants talked about a family member in particular, talked about how, as a result of the tool, since the implementation of the tool, they had seen a positive change
Mm.
in the nurse who was giving care to their loved one. They were, more proactive with their communication with the family member, because one of the things that the tool does is that it really helps providers detect subtle changes in the status of the resident. So
Right.
the care provider then took that information to the family member to investigate and explore, and essentially be a bit more proactive with their care delivery.
Okay, that's great. So this is kind of making me think about a conversation we've had previously about how psychological health and safety relates to this, because one of the things that this podcast is attempting to answer is how can we create psychological safety, a safe space in settings that are oftentimes really complex and also sometimes even chaotic, and then what happens when we do. And so what I hear in your research and the synergy tool specifically is that you're using that to create a space with practitioners and families and care providers. And so I'm just curious, what have you thought about in relationship to psychological health and safety and how that might be showing up as a result of the use of your tool?
Yeah, we actually, interestingly, we also evaluated the impact of the tool on staff, specifically their mental health. I mean, it's not surprising to most of us in the healthcare sector that, you know, rates of burnout are really high among healthcare workers, particularly nurses.
Hmm.
um, I mean, I looked at some research recently that actually showed that the impact of the COVID-19 pandemic on healthcare workers' mental health, that impact hasn't really decreased throughout the waves of the pandemic, as opposed to, some of the other impacts like exposure to COVID, or, contracting COVID and all that because of vaccination and so many other factors. Mental health impacts are not really going anywhere.
Mm.
So we did evaluate the impact of the Synergy tool on mental health, and we did see some positive impacts, particularly in relation to one of the burnout indicators. Um, I believe personal accomplishment and depersonalization were the two burnout elements that we saw some positive changes
Hmm.
after the implementation of the Synergy tool. And the way we went about explaining this finding or this impact is because the Synergy tool actually provides an opportunity for staff to engage in decisions
Right.
regarding workload management, their care delivery, and all that. Those decisions are not made for them without them using this approach.
Right.
Because they're going to be doing the scoring, and they're going to be talking to their nurse manager and leader to let them know, hey, this is how my patient is doing, or my patient load, this is how the scores are changing compared to yesterday. And so it gives them an opportunity to be involved in decision making, which we know from previous research is a really important contributing factor to decreasing and reducing the rates of burnout. Because what is
Hmm.
burnout anyways? Burnout is essentially a syndrome, a workplace syndrome, that essentially, if we were to sort of say it in lay language, it results in disengagement. This
Hmm.
a care worker, an employee, to get disengaged from their work.
Hmm.
So giving them those opportunities for engagement and being a part of the decision making, I think, as we found in our study, actually it resulted in some positive impact. So let me see what if I answered your question. What was your question again?
No, no, you got it. I was curious about how this might be creating a psychologically healthy and safe
Yeah,
space. And you just mentioned, a couple of the psychosocial factors that come right out of the Canadian standard for psychological health and safety. So, workload management is connected to that, as well as involvement. Involvement. And the other thing, when you were talking about burnout indicators, I think one thing that I think, just from my layperson's perspective, on burnout. I'm not, a researcher, but is that burnout goes up when people are out of alignment with their values and the reason why they got into healthcare in the first place. And so if they're not engaged and involved in the process of care and making decisions and having some agency to do that, then how can they be aligned with the reason why they got into healthcare in the first place and their own values? Because I noticed that people that get into nursing and are really on the front line taking care of people, they have a huge value for being able to do things that are going to have a meaningful impact on their patients. And so to me, it just makes total sense that that's what you found.
I'm so glad you're mentioning the important work of Dr. Christina Maslach and Dr. Michael Leiter. And their whole research was on the importance of consistency and a match between um, people's values and wishes in the workplace and what they can actually deliver because of constraints and human resources or financial resources,
Hmm.
so on and so forth. Absolutely. Especially, I can comment as a registered nurse, I can comment on nurses and their desire for delivering, quality and safe patient care, really valuing an ability to be able to, adhere to the professional standards of practice. And unfortunately, because of some of these shortcomings in the workplace, sometimes we do have to cut corners, and that comes with implications and consequences for that particular provider. It causes moral distress, and it causes, burnout. And then from there on, we know that burnout is essentially associated with people calling in sick more frequently,
Right.
or maybe even thinking about leaving their jobs, or even actually leaving their jobs or the profession. So, I mean,
which is as a researcher who's looking at this at such a granular level, an evidence-based level, as you hear the stats coming from the government of Canada saying that nurses are leaving the profession like never before, and that I can't remember the stat, what the percentage of nurses looking at leaving over the next 3-ish years is, but it's very high. Do you remember that stat? I can't remember what it was, but it's incredibly high, and it's because of this.
I cannot remember that stat, but we actually recently published a paper on professional turnover of nurses. And I wish I could actually pull up the paper and give you the statistics that we found, because I think it was, if I'm not mistaken, if my memory is not failing me, I think it might have been maybe 25%, 20 to 25% of nurses are thinking about leaving the profession within the next year or 2 years. I mean,
and do you sense I mean, I'm making a bit of a leap in terms of what the cause of that is. I'm sure there are other factors too, but the ones that you've mentioned have got to be, in that root cluster.
So actually, in our turnover paper, professional turnover paper, and I mean, if people want to look at it, the paper is actually published. So it is available online and it's open access. We actually looked at predictors. We looked at factors that contribute to nurses' professional turnover, a bunch of them, infection control policies or access to, PPEs and whatnot. And interestingly, among all the factors that we looked at, we actually found that staffing and workload had the largest impact on people's professional turnover intent. And usually what happens, because we did look at a bunch of, I guess, mediators, because we were interested in the mechanism through which this relationship happened. What we found was that workload and staffing inadequacies, they result in mental health challenges. And then from there on, people actually start thinking about leaving the profession.
Okay, so we'll link that up in the show notes for this episode. So back to the synergy tool. So of course now the synergy tool is being rolled out everywhere in Canada. It's being implemented in all long-term care homes. It's being used because it's such a great way to, so that's what's happening now, right?
It's not. The synergy tool is, I wish we were there, but we're not.
See, now that's sarcasm, Naz. That was some sarcasm.
Yeah, but you just said it with such a straight face that it was hard to know.
So why aren't people, if this is what did you find about the cost of implementation and the cost of delivering through the synergy tool or evaluating through the synergy tool compared to old models? And if it's not a cost prohibitive thing, then why isn't it being more widely used?
That's a very good question, because in our study, the one in long-term care, we actually did an economic evaluation of the tool, and we actually found that the use of the tool actually resulted in some cost saving for the care homes. This was something that was never looked at before. I mean, to be very honest, I don't know. I don't know why the uptake of the tool has been so slow, but from a researcher perspective, we are certainly pushing for the use of the synergy tool. And, I'm actually working with a number of colleagues in the University of Toronto Metropolitan University. And we have essentially put in an application we're essentially proposing to use the synergy tool, resident needs from the synergy tool, and combine it with simulation modeling approaches to not only gain an understanding of patient needs, resident needs, but also use that information to more objectively make decisions regarding staffing. That application is currently under review. So we don't know if we're going to be receiving funding or not, but we certainly, our goal is to continue to try to push for the tool because, as I said earlier, really the tool helps us gain an understanding of the patient needs using a systematic, quantifiable approach, something that is currently missing in our care delivery approaches. I mean, there are other ways that we're quantifying patient needs, with at least within long-term care, the CMI or case mix index. But the problem with some of those other ways of quantifying is that they're not used frequently. As far as I know, something like the CMI is only being used on newly admitted patients, and it's done only quarterly, as opposed to something like the synergy tool that can be implemented on it really depends on how frequently you want to implement it, because our research actually showed that the use of the tool does not take more than 1 minute. When units are first introduced to the tool, it's probably more in the lines of like 1 minute per patient per resident. And then after care providers get familiar with the tool and the indicators, the length of the use of the tool reduces to 30 seconds per patient. I mean, that to me is a very reasonable.
So there must be a team approach here. I'm just thinking about the whole clinical leadership team supporting the frontline or point of care nursing team. So you're at the bedside with the synergy tool, but I'm assuming that it also must be used in the background for patient care coordinators, clinical nurse educators must be involved in some way. Like it's being used systemically, or how is it being used by the clinical leaders as well?
So in our research project, we actually, the one in long-term care, there are various approaches to how units or departments or care teams decide to actually use and implement the tool. In our long-term care project, we actually started with a training workshop for the adaptation purpose of the synergy tool. And our training workshop had subject matter experts that were multidisciplinary. We had, personal support workers or care aides, RNs, LPNs. We even had allied health involved because some of those synergy tool characteristics, they require multidisciplinary care team involvement.
Right.
And they were involved in the adaptation process and identifying indicators. And we actually also had a family representative and a resident representative who were a part of the discussion and the training workshop, because you don't want to be doing things that are important to residents and their families without their voices being included in the decision-making process. And so this was a training workshop. After the training workshop, in terms of the actual use of the synergy tool and scoring residents, again, because of some of these issues that we have been dealing with in long-term care and, specifically heightened during the pandemic, we actually had to go with a select team of scorers, which to me is not an ideal approach for scoring residents. But this was what we could do at that time, given the staffing shortages and the vacancies that care homes were dealing with. So we had a team of scorers, mostly registered nurses and licensed practical nurses, that would talk to the providers about their residents. And then based on the conversations and discussions with individual providers, they would go in and do the scoring for that resident. In hindsight, again, I would do this differently if I were to repeat this research or replicate this research. And, based on some of the other implementations of the synergy tool in other sectors that we've done, we usually get the individual provider to do the scoring for their assigned patients rather than
Okay.
working with the team. And then in terms of like how the scores are used, I mean, again, it really depends on some of those conversations and discussions that the providers have with their management team, leadership team, and decide together, you know, how do we want to use the scores? Are we using it mainly for the purpose of creating patient assignments, or are we using it for maybe requesting additional staff? Maybe the unit needs a full-time RN to be added to their human resources.
Mm-hmm.
So in one of our projects in surgical areas in one acute care hospital here in BC, we actually use the synergy scores. It's not obviously it's not a long-term care setting, but again, acute care setting. We actually use the synergy scores obtained from their surgical units to come up with staffing recommendations and skill mix recommendations. I'm again happy to share that paper if people are interested. But the synergy tools essentially suggested for some of the units, you need an extra RN for the day shift, or maybe two RNs for the night shift, and maybe an LPN for this other unit.
Right.
So after the synergy scores are collected, we typically bring those subject matter experts together again and use the patient profiles, the synergy scores, to come up with staffing recommendations. What is the staffing level and the type of skill mix required to more appropriately and effectively meet your patient needs, given this understanding based on the synergy scores?
So then you're right sizing your team. It also makes me a bit curious about whether or not you noticed any effect on discharge planning too on the patient side. Was there any sort of throughput that helped discharge planning to accelerate, or to have people leave hospital in a more accelerated way at an appropriate time, differently than the old system too?
That's a very good question. That's actually something that we haven't done yet. And it's certainly in our long list of to-dos with respect to the synergy tool. We haven't done that. But I think the reason we haven't been able to do that yet is because most of the time, the implementation of the synergy tool has not been long enough to be able to essentially capture that impact. I mean, within long-term care, completely a different environment, different context. But within acute care, we do need to implement the tool for a longer duration of time, like 6 months or 1 year, to be able to essentially capture that impact.
So in British Columbia, seeing as that's where you've done your research for the most part here, I'm curious whether in either acute or long-term care, did the synergy tool get picked up as an adopted way to move forward, or did it fall by the wayside?
It hasn't always fallen by the wayside. I mean, with the surgical services research that I mentioned earlier, we actually have been contacted to sort of pick up the project and reintroduce the synergy tool. I actually did have a conversation yesterday with someone in our long-term care partners from the long-term care study, and they also want to sort of pick up the implementation.
So what's driving
of the
that?
tool.
Why do they want to pick it up again?
I think it likely is because of some of the positive impacts that they may have noticed as a result of the implementation of the tool, right? I mean, if the tool gives you an opportunity to be more objective, more purposeful with your care delivery, with your workload management, I mean, you're essentially enabling your staff as a leader, as a manager. You're giving them a tool to be able to make more informed decisions along their care delivery process. One of the other really good things about the synergy tool, beyond workload management and understanding patient needs, is I think it's a very good way of educating your new hires, your newly graduated nurses. because it essentially highlights to them those indicators that they should be concerned about. If your patient has these indicators, these characteristics, this is important. You need to elevate the level of care. You need to go
Mm.
to your senior staff person, get consultation, maybe involve a multidisciplinary care team, call the physician, so on and so forth. So one of our findings actually from the long-term care study was the potential impact of the tool on like educating new care providers, new grads.
That must also provide some relief for those that are senior as well, because even though they still, one of the things I get from new grads hitting the floor and coming out of nursing programs, when I talk to them, is that it can be really difficult to ask questions, just to have a psychologically safe space where they feel like it's okay to engage and to ask questions. What you're describing gives them some framework, maybe a little bit more sort of things to grab onto to feel a little more confident, and also to maybe facilitate more relationship and conversations between them and obviously the patient or the patient's families, but also their colleagues who may not always feel like they've got a lot of time to devote to them.
Absolutely. And if you actually look at our paper, we include a copy of the tool, the synergy tool that we developed for long-term care as part of our supplementary material. And what's really interesting is that it's a one-pager document, and it has all of those important indicators that would suggest to someone, that your patient is not well, that you
Mhm.
need to elevate your care, you need to take this up, talk to someone more
Right.
experienced, and maybe change the care plan. So it's a really good educational tool. And yes, absolutely, it creates that environment for new grads, for new hires to know it's okay. It's okay to take this to someone, go to someone more experienced and say, this is what I'm seeing. This is what the tool shows. My patient is having these indicators that are
Right.
essentially suggestive of, high needs. What do I do? Where
Yeah, it
do I
gives you
go
a
from
bit of a
here?
buffer. You have a little bit of,
Exactly.
it's not about you, it's about this. So,
Exactly.
right. So
Exactly.
you
And
can
you
have that
and
conversation.
it's a one pager. It's
Yeah.
very practical. It's not like
Hmm.
a book or a manual that's long and not very accessible. It's a one pager, and it's a document that is very accessible, because at the end of the day, it was developed by, or it is developed by subject matter experts
Hmm.
that are from within that unit and really know
Right.
the patient population.
That's amazing. That's so. How long does it take to implement this program in, say, one unit in a long-term care facility? What could a manager or leader expect to take in terms of time to use this new approach?
Yeah, so as I said before, the actual scoring is very quick to do. It takes somewhere between 30 seconds to 1 minute. When people get comfortable with the tool, it's more in the line of 30 seconds in the beginning, maybe around 1 minute per patient. The actual program, it really depends on how long units and departments actually want to and have the resources to implement the synergy tool with their patients. I've seen a variation, I've done a variation, I've been in projects where the synergy tool was implemented on a daily basis for 2 months. I've been involved in projects where they have done the implementation for, I don't know, 6 months on a weekly basis. My overall recommendation would be that the longer and the more frequent that the synergy tool is used, the more robust and trustworthy the data. In terms of the training workshop, it usually takes 2 full days. I mean, in long-term care, we did it about a day and a half. And the reason being is that we actually had an opportunity for a pilot before the start of the research project.
Mm.
So we had the backbone of a tool before the actual CIHR project got started. So we were able to sort of shorten the time frame of the training workshop to a day and a half. But typically around 2 days is what we recommend. And then after the data collection period, it usually takes our team probably somewhere in the realm of 1 to 2 months to analyze the data and create those patient profiles based on the synergy scores. And then if units and departments are actually interested in informing their staffing decisions, staffing models based on their patient profiles, there needs to be typically a 1 day training or discussion or workshop where, again, you bring subject matter experts together, look at the patient profiles, and maybe you want to even have your HR director involved and, have them be a part of the discussion and then decide together what our staffing needs.
Amazing. Excuse me. That's amazing, Naz. So we're going to start wrapping up. But before we wrap up, I'd love to hear what you're seeing in your engagement with nursing students, because obviously you're teaching nursing students all the time. They're in your class, and then they're coming out. What are you learning? What are you noticing that you think is important for people to know, especially leaders and managers?
In relation to the synergy tool, or generally speaking?
Well, I mean, just whatever comes to mind that you feel like is important, that as a professor you're noticing and engaging with those students.
Yeah, very, very good question. I mean, there's a long list of recommendations that I could share, but I would suggest that take mental health and psychological health and safety seriously, and nurse leaders and nurse managers. If you see those early signs or warning signs in your staff person, take it seriously. It has serious implications. Burnout has serious implications.
Right.
Exhaustion has serious implications for not just for patient care delivery, but for the organization, for the unit, and for our workforce, generally speaking. So
are you finding that nursing students are concerned about that? Are they talking about this?
Oh, absolutely. Absolutely. I mean, I don't teach in the undergraduate program anymore, but when I did, our undergraduate students, I would say there was almost a sense of surprise and shock when they would go to clinical rotation. They're like, wow, like this is very different from what I anticipated, or what I was sort of thinking I would see. It's tough, and it takes a lot of resilience and a lot of self-care to be able to survive well. So
what about the master's students? What are they talking about?
Master students, I would say they're mostly issues that are of concern to them. Not very different from undergraduate students, although that sense of shock is not there anymore because they've done it for a few years by the time they get to me. But again, concerns about staffing, concerns about workload. But what I find with master's students, because I'm privileged because I actually teach a leadership course, is learning from them what a big difference their relationship with the leader, with their manager, with their supervisor, actually, what a big difference that makes on their ability to be able to survive well in a complex environment. So my recommendation for my second recommendation for nurse leaders and managers out there would be invest in your relationship with your staff. It's going to pay off.
This is so important what you're sharing now. You're kind of singing from my song sheet a little bit, because one of the things that I notice in my work is that there's a clear disparity between managers and leaders who create that relational equity as a foundation for their operation, compared to managers and leaders who are just trying to get tasks done. And it's so, and in fairness to those that are really driven by that sort of task management perspective, oftentimes those managers and leaders are dealing with their own anxiety or their own sort of angst about getting things done. And there's a transition they're in to leave sort of hierarchical approaches or command and control approaches and do something that's more relationally based. But how am I going to get everything done is kind of the first objection that I hear all the time. But I was just thinking about an interpersonal or interprofessional paper I read, Transforming Team Culture, a case study in critical care, and I'll post that in the show notes too. But it talks about doctors and nurses and coming together to do care, and how relationship was the foundation of the operational efficiencies. And what actually happened was that people got to know each other in a different way. They felt psychologically safe, and they talked about what they really needed and wanted. And that became the grease on the wheels, so to speak, for what happened afterwards. And the study's clearly saying this is what we need to focus on. And so it makes me curious, as you're teaching leadership to master's nursing students, and you hear what I just shared, and you think about sort of that relationship that being the foundation, what are some things that you could share with managers and leaders that are really struggling to do that? It's not that they're not capable. It's maybe that they've been doing it a certain way a long time, and so now they're being asked to do something different. And I know for myself, I had to make that transition, and what I felt like at that time was afraid. I'm afraid I'm not going to get everything done if I do a different approach like this, and embed myself on the unit with my staff and my team. Man, how am I going to get everything else I've got to get done? All the emails, all the things. And now I know now on the other side of it, what happens is that you actually do get things done in a much different way. But I'm curious, what would you tell those folks that are struggling with that sort of internal angst?
Yeah, I think that's a very good question, because I'd like to first start by saying and acknowledging that, yes, as a leader, as a manager, you obviously have commitments to your organization. You have timelines, you have, budgets, you need deliverables. I mean, that's certainly very important as part of your commitment to the organization, but it's not enough. You need more than that to be able to actually, um, deliver your commitments to the organizations, because we know when those staff managerial relationships, when they're absent, that eventually at the end of the day, it's the organization that's going to suffer.
Mhm,
Those
mhm,
people are at a higher risk of burnout. They're at a higher risk of leaving the organization and more likely to call in sick. So it goes a long way
mhm.
to invest in your relationships with your staff. And it doesn't always take that long, to be very honest. I agree with you, Trace, in that I think it's the issue might be, other than workload, lack of time and resources, because that's always a problem, is us getting into a habit of doing things a certain way. But
Mm,
it doesn't have to be that way, right? It doesn't need to take a very long time. It could be simple things, as like maybe just spending a few minutes to get to know your individual staff person.
right.
Maybe in some of the discussions or team meetings that you have, it doesn't always have to be in services. Maybe spend the time to get to know each other personally
Mhm,
and learn about each other's values and life story, to essentially try to build and create those relationships. Don't be afraid to acknowledge good work and say thank you, right? Personally, have an open door policy. Create opportunities for your staff person to be involved in the decisions that you make,
mm,
and not just get their input and feedback and do nothing with it. Actually, you use the information, use the feedback to inform the decisions that you make. And
mhm,
if there are situations where the feedback cannot be incorporated or integrated into the decision, be transparent about it. Keep your staff, keep your employees in the loop regarding the decisions that you make, the rationale behind them, and essentially all of this with an eye to make the staff person feel like they're involved, that they're
Right.
important to you, that they're
Right.
making a big difference.
Yeah, thank you so much for that, Naz. I really appreciate the work you've done with the Synergy tool as well, because I think that anything we can do that takes operational processes and incorporates that safe space of relationship as well, so that we're engaged and everybody's contributing, has such a powerful effect. So I really am holding the intention with you that that is a way of working that will become prevalent in Canadian healthcare. So thank you for your work, and thank you so much for being here. I could just keep talking to you for another hour, but I think we better wrap it up now. So how can people get in touch with you?
My contact information is available online. If you
Okay.
search for my name, UBC School of Nursing, it usually shows up. And I'm happy to hear from anybody who might be interested in Synergy tool or any other work that I've done around quality, safety, or health system research. So
Awesome. Thank you. Thank you again for being here, Naz. It was great to talk to you.
excellent. Thank you so much for having me.
Thank you so much for listening to the show. And if you have any comments or questions, please reach out to me on LinkedIn. I look forward to seeing you next time, either online or in one of our programs. And until then, remember to be a safe space. Thank you again for getting to the end of this podcast. And if you enjoyed this and you found that there was value in it for you, my invitation is for you to subscribe for future episodes that come out weekly on Tuesdays. Thank you again, and I'm looking forward to being with you next time. Now remember to be a safe space.